There's actually quite a lot to cover today. We're going to, it's a very broad topic, antimicrobial stewardship, and it isn't the most interactive of presentations, to be entirely honest. I mean, the real interactive work is going to be done at the face-to-face workshops, and I think Nick sent an email out about attendance. We're just trying to sort out catering and stuff for the day. So if you are able to clarify which members of your teams are coming, obviously the Jersey team are going to be attending remotely, but there isn't really a remote option for many others. We really want people to come in person, actually, because it's going to make it a lot more rich, those discussions. But we're going to frame today's session on Start Smart Then Focus. And as you hopefully all know, that this is kind of takes you on a journey from the starting point when a child arrives to what you do initially, the sort of Start Smart bit, and then the bit about what you do afterwards in terms of what at a time point, which might be 24 hours, might be 48 hours, 72 hours, but it's the then focus bit. And all of these bits require some consideration, and we're going to really be trying to drill down into relevant pediatric bits. I mean, but some of this is also adult stuff. Adults and children are probably more similar than they are different. However much we don't want to accept that, but there are some definite differences as well. So we'll talk through both. And I think the first bit to talk about where there is a marked difference is sepsis. And I could have written not all fever is infection, but actually fever is generally infection. So this isn't going to be a session about talking about all the differentials of fever, including Kawasaki disease and oncology stuff and rheumatology. Yes, a very small proportion of children with fever present with non-infectious things, but the vast majority of children with fever, over 95%, have an infection. The challenge we have in this country is that people have almost moved to a default, which is all fever is sepsis. But we're then going to move on to talking a bit about diagnostics and diagnostic stewardship, a bit about the process of prescribing, breaking it down into how quickly, use of guidance. We will talk a bit about allergy, because I think allergy does have a big impact on AMR, and a bit about spectrum again. And also the importance of how one documents things when it comes to the next person seeing the patient. And then we'll talk a bit about the focus bit. And this is really going to speak to IV to oral switch as well as other bits and pieces. So yeah, not all fever is sepsis. And this picture, it's not just a pretty picture, albeit it is a pretty picture. It's of, this is of a neutrophil engulfing, ingesting a bacteria, Klebsiella pneumoniae. And the relevance of this picture is that we have immune systems. The majority of children we look after have immune systems. And actually, the immune system is a highly effective way of controlling infections. And we know that because when we take away the immune system, especially by giving children chemotherapy, children with cancer, then they are highly susceptible to quite horrible invasive bacterial and fungal infections. So I find this kind of graph quite difficult because this is a graph from 1999 through to 2017 of sepsis rates. And you'll see there's been this massive surge, a huge increase in sepsis rates. And actually that increase is entirely because of the narrative in this country about the sepsis saving lives. The sepsis campaign just asked, could it be sepsis? And clearly, as an infection specialist, I think it's fabulous to be thinking about sepsis, absolutely. But however, the problem we have is that we look after children, and the proportion of these cases of sepsis or sepsis in children is dropping year on year, and that's mainly because of the fantastic vaccines we've introduced over the past 25 years, the conjugate vaccines, especially that protect our youngest children because they align with T cells and T cell immunity. And so almost the first question that I ask myself, and I kind of have quite a strong view on this, which I might kind of get across slightly, is this question about, has the UK sepsis campaign had an overall negative impact on children? Actually, deep down, I think it probably has had a bit of a negative impact on children. And as I alluded to just now, our vaccines have just done extraordinary things. And the new vaccine on the block soon is going to be the chickenpox vaccine. Clearly, chickenpox is a virus, but it does make you highly susceptible to group A strep and Staph aureus, but especially invasive group A strep. So we've had lots of very, very effective bacterial vaccines over the past 25 years that has saved countless numbers of lives of children. And although this is a talk on AMS, this whole entire program is an AMR program. AMR is still the overall tenet, and promoting vaccines and vaccine uptake in children and pregnant women is absolutely a massive thing for us to do, because that will have as much impact, if not more, than the work we do with antimicrobial stewardship, at least in terms of AMR. So going back to sepsis, we have these national reports of deaths in children, national child mortality databases, and I think the most recent data, it comes every 3 years, and we do another batch relatively soon. Next year we should have the 2020, maybe the year up, we'll have 2022 to 2026, 5. But in that year, infections make up a proportion of child deaths. But I think that the reason I wanted to bring up this slide, and I find these numbers quite difficult, to be honest, but is that the majority of children who die from infection have underlying health conditions. And actually, a lot of them are neonates. So a lot of those deaths are in under 1-year-olds. Those are often babies on neonatal units. So sepsis deaths are clearly, they occur in non-comorbid children, but the majority of infection deaths happen in children, and these are directly attributable to infection deaths, happen in children without comorbidities. With comorbidities. The other group to clearly think about is the most children who we find it hardest to offer, who find it hardest to seek healthcare, and these are children from ethnic minorities and children living at significant levels of deprivation. And as I said, vaccines are important. Sepsis does happen. Chickenpox we take very seriously because of that association with group A strep. And finally, in this country, we're bringing out a chickenpox vaccine at the start of next year. But the issue, and I'll talk through some data in a moment, is this concept of query sepsis, and how we have almost moved away from stratifying infection to classing everything as kind of sepsis, and not recognizing that there's this concept of septic shock, rather than something that is just potentially some moderate derangement of physiological factors that may be a transient phenomenon or may just be linked to one organ system. But septic shock is a whole body thing, obviously, and you just don't have one bit of the jigsaw. You're tachycardic, you're tachypneic, you've got reduced increased capillary refill, your lactate goes up, you then get altered levels of consciousness, and all of the above. Your blood pressure finally drops. That's clearly quite late. But septic shock is clearly a life-threatening emergency, and the things below it are potentially life-threatening. But we do need to distinguish between them, because if we rush headforth into a 1-hour approach for every child with fever, we're going to end up generating a lot of harm for children. And that's kind of what we are doing in this country. And we know that because when we look at antimicrobial prescribing, we use vastly more ceftriaxone than almost any other country in Europe, or then any other country in Europe, and that's because of the sepsis narrative. And then when you look at the sepsis screening tool produced by the UK Sepsis Trust, we all know what these look like, and the sepsis 6. And here you've got these red flags, any red flag things present. And what I find very challenging is that any red, so even if you have one, which is an element of respiratory distress, grunting, apneas, clearly that's significant respiratory distress, don't get me wrong, or you're hypoxic with SATs under 90, you immediately flag. And if you immediately flag, you're, according to this at least, and this is an approach adopted by many hospitals in the country because people are very scared about deviating from the sepsis narrative and the UK Sepsis Trust mantra, is to then give IV or intraosseous antibiotics. So this suddenly means that almost every broncholytic child, in addition to getting senior input, and this kind of doesn't quite align with NICE, because the NICE, if you read the NICE guidance clearly, yes, your flags should trigger a senior assessment, and a senior assessment should then decide whether IV antibiotics are required or antibiotics are required. But here they're being brought at an equivalent level, and I think this is kind of one of the issues we have. And for adults, this may be entirely reasonable, but for children, we have so many children presented with respiratory distress. Seb, do you want to come in here, or?
Hi, Sanjay. Sorry, I did join the party a little bit late, but I'm pleased to see Andrew and Judith in the background. Yeah, it was just interesting hearing that, because the idea of a senior clinician being the rate limiting step, and I'm saying this slightly jaded from being up in ED most of yesterday, is that I don't think we can rely upon seniority almost as an automatic rational voice in this at times. There's less and less confidence around that. I sometimes feel I'm a bit of an isolated dinosaur in terms of saying, "Whoa, hold your horses and back off." But anyway, I'm just sharing that as part of it. But I fully agree with everything you're saying. Otherwise,
I think that's right, and I think that's exactly what I was trying to get across. Apologies if I didn't quite, but it's just that we are making it really difficult for senior clinicians who are reviewing these children to then withhold antibiotics, because if you kind of look at this closely, it does appear you've got to be pretty brave or feel pretty brave to almost be going against what's on this guidance. And I find that we're putting our clinicians and frontline clinicians in a very difficult position. And we looked at this. So this is a very small audit conducted over a few months in August of last year, where 31 children who had triggered the sepsis screening tool were reviewed. Their notes were reviewed retrospectively. Unsurprisingly, the majority of them were less than 5 years of age, more than 75%, and very few had pre-existing medical conditions, as expected. They were all pretty much seen within an hour. So the impact of this sort of sepsis screening is massive on time spent by senior clinicians reviewing these children. And I'll come to how many got antibiotics in a moment. When you look at their biomarkers, very few had high CRPs over 100, only 13%, and less than a quarter had CRPs over 50. I'm not saying the CRP is everything, but it's giving us a little bit of a flavour of potentially how many of these actually had invasive bacterial infections. It generates a huge number of blood tests for the same reasons that Seb sort of said, that it's hard to withhold the antibiotics. It's hard to do, like to just hold your nerve and just watch these children. And then when you look at their antibiotic prescribing, they were pretty much most of them were given antibiotics. That aligns with the observation made by Seb. And they're given pretty quickly. Nearly all of them were given within 3 hours. So this whole bit about and the approach that we're now adopting for the very small children with severe sepsis, absolutely give antibiotics quickly. But for the rest, you've got a permissive approach to actually spend some time observing the child, potentially doing some investigations, waiting for them to come back and making a rational decision about whether they need antibiotics, and if so, what infection you're treating. So you don't have to dive into the cupboard and just give them ceftriaxone. But that's not happening at the moment, because all of these children are getting a third generation cephalosporin. So, really difficult. And then when you actually look at how many of them have positive blood cultures, and once again, a blood culture is an absolute gold standard for telling you it's an invasive bacterial infection, but it's not a bad yardstick. And if only one of those children out of the 30 odd, and that was a child with a comorbidity. So it's just really interesting. I think we've swung so far one way with sepsis that is causing a tangible harm to children. And when we actually look at this objectively in terms of what we know about the data, this is from the Perform study, a big European study that I've spoken about before, because some of that ceftriaxone prescribing data comes from it. That actually very few children, less than 1% of children presenting to ED with a fever, have a severe bacterial infection that requires antibiotics within an hour. And although 5 to 15% may have a UTI or a pneumonia or cellulitis, all of those will fall into the category of a serious bacterial infection. Reiterate, very few. And even when you look at neonates, and clearly children under 3 months of age do have an increased rate of invasive bacterial infections and severe infections compared to slightly older children, even that rate was still very low. Very few have a growth in the blood or CSF, and although the absolute number might be a little bit higher than that, it's not still high. And so we are really we're really faced with a very small number of children, including neonates, that have got severe infection, life-threatening sepsis. I stumbled upon this quite recently, actually. This is our poor colleagues in primary care find it even harder. We sometimes do have tests. We can do blood tests. We do X-rays. We can, we can wait for urine to be produced, etc. And it gives us a little bit more information if we haven't just dived in and given them Ketorolac within half an hour. But in primary care, there's a real worry. The litigation aspects of medicine have made people very fearful of not prescribing. And this is some adult, all age data, actually, with on that graph on the x-axis is age in 10-year periods or something. And on the y-axis is logarithmic. It's the number needed to treat to avoid a case of sepsis. And you'll see, firstly, that UTIs, respiratory tract infections are very unlikely to result in severe sepsis. So clearly your infection generally starts somewhere. Invasive group A strep might be an exception where you just get a bad treatment, you get toxic shock syndrome. But for most other things, you're treating your primary infection. And RTIs, respiratory tract, very unlikely to result in sepsis. UTI is slightly more so. You're more likely to have urosepsis, and that's why the term urosepsis is a term that we've all heard of. Respiratory sepsis, a little bit less so. You might get sick in the chest with a bad pneumonia or an empyema, but to cause total hemodynamic instability is much rarer. But the bit that is relevant for us is that children have a far lower rate of that conversion to sepsis from a focal infection than adults. For a myriad of reasons, but the numbers needed to treat are massive to avoid a case of sepsis. And I think that's the kind of thing that we need to know the pre-test probability of things happening that we're worried about in order to make rational decisions about prescribing. And I spoke a little bit about the sepsis trust, but actually there is a recognition that things have gone a bit wrong with children. And so the Surviving Sepsis campaign relatively recently, this is 5 years ago now, made it clear that we do have this permissive approach to children with sepsis or associated organ dysfunction, but without septic shock. And with those, we have more time to decide where the focus is, if it's bacterial, if it's viral, where the focus is, and then to give a targeted antibiotic, which may well be an oral antibiotic, such as amoxicillin, or may well be nothing because the child in all probability has bronchiolitis or has got a viral lower respiratory tract infection. And this has been converted into a reasonably complex flowchart that I personally don't use, but mainly because I don't do stuff down in ED so much. But this is produced by the Medical Academy of Royal Colleges as part of this bundle of work that's trying to translate the surviving sepsis information, and it uses the PEWS, the Paediatric Early Warning System, scoring to give us an idea about who needs that kind of life-threatening management, which isn't just antibiotics, but is also resuscitation, it's fluid management, it's organ support, it's potential tubing and all of that, and who we can adopt a more permissive approach. And they break it down into 3 hours and 4 hours. I think it's almost a little bit confusing, but that middle group, which is still a small proportion, the majority of children are noughts and naught to fours. You have lots of time to decide which investigations are required and get those back, many of them, before you make a decision about antimicrobials. We don't have to dive in within an hour. And NICE, I think, are trying to recognise this. There's been a lot of noise from many people around the country about the harms of their sepsis guidance and how it's been translated by the Sepsis Trust. So I believe, although it's not totally transparent, that they are reviewing their paediatric recommendations as part of this guideline update, which is expected to be published next month. Okay, a little discussion about diagnostic stuff. Blood culture volumes matter. So this is, I think, a really almost an easy win when we're looking into stewardship-related quality improvement things. So we do rely on blood cultures quite a lot. Clearly, if you audit it, and this is just the findings of a QI study done somewhere in I can't remember where, this was maybe in Ireland, where they looked at nearly 1,000 blood culture, nearly 400 blood cultures before their intervention. They put in an intervention to try and explain to people why you need to take appropriate amounts of blood. And then they looked at the amount of blood in bottles by weighing them afterwards. And you can see a tangible improvement in the volume. Percentage of blood culture bottles was adequately filled. And our recommendations are that, you know, for our youngest babies, we recognise you're not going to get 4 mils on a prem baby on the neonatal unit. So we're trying to get half a mil. We're trying to get 4 mils in babies over 3 years of age, and something in between for children in between those two age bands. And that's because the yield from blood cultures is proportional to the amount of blood in the blood culture bottle. And for this group, for their quality improvement project, they found that a pathogen was detected in 10% of cases when you had adequately filled bottles, compared to just 2%. So if we're making decisions about stopping antimicrobials on the basis of a blood culture, it seems a little bit trickier. Although, you know, if you just spun a coin, in all probability, the blood culture is likely to be negative, because the majority of paediatric blood cultures taken are negative. But you are increasing that likelihood of it being negative if you actually don't put enough blood or no blood into a blood culture bottle. And this is some work from the fabulous team in Portsmouth. So we have Andrew on the call, and this is work that Andrew and Tash and others conducted a few years ago, where they looked at over 1,000 thousands of blood cultures. And this speaks to the then focus bit of it. But because we felt like the right time to present these slides, that actually you don't need to wait for 48 hours to get a negative blood culture result for pathogens, and that's the red line. You know, over 90% of them were positive at 24 hours. That's about 96% of them were positive at 24 hours. So this isn't referring to comorbid children with central lines in where it might be coagulase negative staph. This is community-acquired pathogens. The green line is contaminants. So clearly you are going to get contaminants, and we contaminate a lot. We get a lot more contaminants than we get pathogens in blood cultures, but they usually take longer. So, you know, if you're waiting for all of your things to grow, yeah, you'll be waiting 24 hours, but your additive yield beyond 24 hours is not much beyond contaminants. Andrew, do you want to say anything there?
Thank you, Sancho. Bless you. You actually point out just about saying absolutely in terms of this is community-acquired pathogens, and we recognise, of course, that coagulase negative staph slower growing, take a bit more time. But no, we're very reassured, and it's nice all in terms of those community-acquired pathogens, the E. coli, the Group B streps, the Group A streps, those which community pathogens would take actually the majority within 24 hours, and all within 36. And actually, after 20,000 blood cultures, my colleagues of IT trawling through data, we were very reassured on that.
No, indeed. And I think we should also not think that this only applies to older children, this kind of reading them at 24 hours, when they then subgroup analyze the data based on age. Actually, neonate positive pathogens from neonates yield, you know, a very similar timeline in terms of that 24-hour prediction. So, you know, I think we really should, you know, what we're saying that we need to wait to 48 hours is not appropriate for community-acquired infections at all, and it will reduce exposure to antimicrobials and impact the families coming back and all of those things we spoke about in week 1. A little bit more about diagnostics. I'm not going to say much more, but we work together within our Wessex ID network, ID immunology network, and we're about to draft or finalise some information about molecular testing, respiratory viral testing. It's obviously more than just respiratory viral testing, because some of these platforms have bacteria on as well. So you get higher rates of colonization in children than adults, and so sometimes the ability to interpret pneumococcal results, mycoplasma results, etc., from pediatric samples, especially from young children, where those rates of colonization are high, is very difficult, and it can actually end up either making us make an inappropriate decision or to inappropriately treat something that isn't causing any problems because it's a colonizing agent. And there is help at hand, and I do hope that these pathways are implemented at every hospital across Hampshire and across Wessex, because they provide really clear guidance on the management, starting right from the differentials. Without the right diagnosis, you end up going down totally the wrong route with infection management. It gives you an idea about assessing the severity of illness, and in my opinion, that it's the severity of the illness that dictates whether a child needs antibiotics or not, and if they do, whether it's IV or oral, and also how quickly they get them. It also provides some information about, you know, diagnostics and imaging, and the role of diagnostics, when it's appropriate, when it's indicated, you know, what red flags should prompt you to do more imaging, information about source control and when it's required and when it should be considered, information about admission versus ambulation, and then bits about IV to oral switch and total duration of antibiotics. So a wealth of information there. And there's a poster that can just literally be printed out and put in your ED on your paediatric wards, and it's on the it's on that Paediatric Pathways website. If so I really, and that would make a really nice QI project. I think we will think about what things come of all of these discussions and how we start benchmarking things across the region. And these are being updated as we speak, linking in with the Royal College of Paediatrics and conducting another literature review. Andrew.
Sorry, it's me. Sorry, I just missed, I'm not sure if Emmy said, they're available now for us to look at on this Paediatric Pathways site, but we haven't incorporated
as well. I think we put them all on the peer website as well.
Thank you.
We should all be, and we'll audit. Once you've got guidance, you can then audit against them. So it'll give us an idea about whether we are using them and whether we're aligning with them. Seb.
Sanjay, I don't know if it's the right moment to ask. And listening to this, I as you know, I completely sort of on board with the pretty much everything that you're saying, really, in terms of, yes, we are probably over treating, clearly. Yes, there is this, I shouldn't use the term, but there is almost that hysteria around, could it be sepsis, which has probably swung the pendulum way too far. And so then there's the practical bit, which sort of is hard to fit in within this, is for example, I will give this is an anecdotal example, but this is the reality, which is, say, what I experienced yesterday evening, which is a fairly heaving, chaotic emergency department setting, a lot of demand, a lot of expectation. So you've got all of that pouring away, families who've ramped up about sepsis, 111 that's ramped it up, all of that. And you're wedged in between, because it so happens, but not unusual, no room at the inn, very few beds, if any, and trying to juggle that, knowing that the majority of those hot children probably don't need anything, but not having the luxury of staff or time or space to accommodate that. And that is the difficult juggle, which means that, there are times where we will sort of, I and others will probably sort of empirically throw antibiotics at children and young people, recognizing that is that evidence-based. Ironically, I've just been interviewing for a consultant post and talking about those difficulties of, you're in that leadership role and you're there with a workforce that may be not enough or quite inexperienced, with a population that is worried. And that is the hard bit within all of this to kind of tease out in terms of the practicalities, but it is still making that call of, yep, no, you don't need anything, or yes, you do.
I think I agree with everything you said. You're right. This isn't that we're probably not going to delve into that at the moment. We have, we've got loads more to cover. We can maybe touch on it in the Q&A at the end, but probably more appropriately to bring it into the workshops we run in a month's time. I think that this is the kind of thing where you do need a group of people together to work out in your setting, because your setting is not the same as my setting necessarily, or the setting in Dorchester or on the Isle of Wight. And so that's why this concept of infection teams that come together is absolutely crucial, because actually I don't have the answer to that question because I don't work in your ED, but actually some thought from a group of people who are credible and have leadership roles like yourself and Andrew and Judith and others actually does potentially, might not offer the answer, but might offer some tangible things you could try. They may or may not work, but then you need to try something, and you need to be data driven, obviously, and all of those things that go with trying to change behaviours. But some of this, clearly it's really difficult, and it's difficult for all the reasons you've said. It's a strong narrative, and we work in a resource poor setting. Almost a low and middle income countries kind of setting in many ways, where we're expected to make quite medical legally justifiable, risk averse decisions. So yes, very challenging. I might talk a little bit about prescribing and communication. I'm not going to say anything about the urgency, because we've spoken about 1 hour and 3 hours, except that many people are still using, or we are across Wessex, using the peer sepsis screening tool. So this is kind of an adaptation of the Sepsis Trust guidance. So many people around the country use the sepsis guidance just as it is. And that is hugely insensitive in terms of lots and lots of low specificity, I mean, so lots of false positives that generate overuse of antimicrobials. We've tried to be a little bit more nuanced, but still it's pretty blunt. We've added in something more explicit about children who don't have severe sepsis or children with comorbidities, significant comorbidities for rapid deterioration, and providing a more permissive approach to those. That's all in the sepsis screening tool. But this there is a bit about the first decision about antimicrobials is that they needed a tool, and I think are probably maybe worse than our primary care colleagues at deciding whether they're needed or not. For us, it's often, is it ceftriaxone or amoxicillin, as opposed to is it nothing or amoxicillin. And so there is clearly, there are approaches we've taken. Our primary care colleagues have the SCAN guidelines. I've supported sort of some of the content of that. We use something similar for theory. We use something similar on our Wessex empirical antimicrobial guidelines. And ICE have got information about otitis media. We use a fever pain score. So there are various approaches, and scoring systems I think are good. I'm not a big fan of the viral bacterial paradigm because I think it's just really hard to pick, especially in primary care. But even for us, when we've got this myriad of tests available, it's very hard to interpret PCR tests telling you whether this is a pathogen or just something that was there previously without CT values and all sorts. So I think it's difficult. Biomarkers might be useful. They're also pretty blunt. So I would, we do offer some guidance to those paediatric pathways. So I do think that that first question should be, are antibiotics required, as opposed to which antibiotic is required. But we also need to be cognizant, and NICE do show some recognition that one size doesn't fit all, and that tiny box there says high risk of complications. But actually, for us in paediatrics, my approach is there are certain children who I would expect a lower threshold and a more permissive approach to antimicrobial prescribing. And that might be oral antibiotics for chest infection in primary care or ED. It just doesn't mean they need ceftriaxone, but mainly because all antibiotics are extremely good, as I'm going to tell you in a moment. But I think if you've got a severe immunodeficiency, so my children with severe, they may already be on prophylactic antibiotics, but when they develop a cough and things like that, they're much more likely to end up getting a treatment course of an antibiotic, which may be Amox or maybe carboxyclam. I think if you've got chronic, you're an ex-prem with chronic lung disease, still needing overnight oxygen or ventilatory support, you're a child with tracheal issues, still on ventilatory support, I think those are the ones that I'd have a lower threshold. If you're uncorrected hemodynamically significant congenital heart disease, you're under 2 and you've got CF, although that bit may change in the world of these new treatments, or if you've got one of these awful neuromuscular conditions and you're getting quite intensive ventilatory support, I think all of those, I would put into my equation for lowering my threshold. But the honest truth is 95% of children do not fall into those categories. And so most children, you can take a more pragmatic approach to prescribing. But there are some where I think the rules and the studies that we quote don't quite apply. We love ceftriaxone. We love ceftriaxone in this country because it's once a day, and as Seb said, you can just whack it in and send them home, and then they come back, and you've got no space at the inn, and nurses are happy because they're not having to give antibiotics 4 times a day, and the cannula lasts longer. But it's not cool, actually, and I have subscribed to that for many, many years, and I'm feeling more and more uneasy with it. And clearly for these kinds of things, oral antibiotics would be fine. Or if they need IV, you can go much narrower. Fluclox, would be good for cellulitis. Amoxicillin would be fine for a sore throat in a children that's not tolerating enterals. IV if you needed it. Penicillin V ideally. And we have provided this kind of guidance for sensible antimicrobial use. We're not all roads lead to ceftriaxone at the moment. And we've worked really hard in national guidance. We've moved away from the Wessex empirical guidance, and we now work collaboratively with colleagues around the country. So these microbiologists, pharmacists, PEDS ID people, ED people, etc., to develop some accessible, clear, evidence-based guidance. This is live guidance, so whenever new things are published, we're able to review guidance And in addition, this group meets 4 times a year. There's no dosing guidance in it because the dosing guidance is from the BNFC, but we are able, as this special interest group within the Royal College called WPAS, are able to influence or inform BNFC of potential changes. So all of this is now available on the OLAS app, which you get signposted to this now through PEER. Most people look for guidelines via PEER, and all of our empirical antimicrobial guidelines are accessible on PEER. Clearly, some children do need to go a bit broader. You know, if you're septic, often if you've got a CNS infection, because you need something that's got good penetration to CNS, which is something like a third generation cephalosporin. You've got neutropenic sepsis, you've got to cover additional bugs like Pseudomonas, so you're often going to be on something like Tazocin. You know, obviously, if you're known to be colonized with a resistant organism, if you come from an area with very high rates of resistance, so you've just come from a hospital in India where you've been an inpatient and you then appear in the UK, I suspect you're going to be covered for a far more resistant organisms empirically until we have microbiological evidence of and we can target therapy. And potentially, and this is probably the weakest one, is if you fail first-line treatment, because actually the reason most people fail first-line treatment is not because their antimicrobials are too narrow, but it's because they either need source control or their pathology is non-infectious. And so the whole cycling of antibiotics, and we see this with NEC a lot, you know, babies on the neonatal unit, they start first-line antibiotic, which might be a Mox, Gentin, Metro, it might be Vanc, Gentin, Metro, and then they deteriorate, their platelets plummet, their abdomen looks dreadful, and actually what they need is source control. But invariably they're switched to meropenem plus Gent or whatever, and that's not a failure of first-line treatment, it's need for source control. And so those are the main reasons why children need broad-spectrum antibiotics. And occasionally, and this is rare, that they've got a proper penicillin allergy. So we'll briefly talk about this. You know, more than 10% of the UK population have a penicillin allergy. That allergy is often applied in childhood. However, you know, earlier, you know, having it applied in childhood almost invariably means that you don't have a penicillin allergy. You know, over 95% of children labeled as a penicillin allergy are not actually allergic to penicillin when they're formally challenged to penicillin or beta-lactam. And clearly when adults are labelled with a penicillin allergy, it's more likely to be a real penicillin allergy, because all of these viral exanthems that children get and they then have disease from, because they've not been pre-exposed to them and don't have antibodies and immunity to, can generate rashes. They then go to somewhere, ED or primary care, get some antibiotics, and the timing of commencement or 2-3 days later when they develop a rash is often ascribed to the antibiotic. However, if you label someone with a penicillin allergy, clearly the impact will be that they're going to end up with a non-beta-lactam antibiotic, such as clarithromycin or azithromycin. And when you do that, you end up having worse out because they're not as good. You end up having more adverse drug reactions. You drive more antimicrobial resistance. And overall, in the long term, these patients have worse mortality, morbidity at population level and higher rates of AMR. So it really is it has a significant impact on patients, incorrect labeling of penicillin allergy. And clearly, it's much easier to avoid applying a penicillin allergy label in the first place than taking it off. Because taking off is a bit of a faff, because once it's on, it's a bit like sepsis. You know, you don't want to go against the kind of decision that someone has made before you. And so you just carry on. And so it takes a bit of courage to then expose, you know, to say, actually, I think that's not right. We'll come to that on the next slide. And for me, that 1 hour, the onset of symptoms within an hour of exposure is a really useful yardstick. Now, if the onset of symptoms was 6 hours later, 24 hours later, 3 days later, you know, that's really pushing you towards, you know, that is not an allergy. And this is what we need to teach our primary care colleagues. And I've just been doing some teaching with them just prior to this teaching, actually. So, you know, we need to get this message out because it's having an impact on children. And all of this kind of stuff is on the Healthier Together website. And this is there for penicillin allergy delabeling. If you want to be courageous and try and take a label away, well, then actually you need to take a clear history of what happened. And if the reaction happened within an hour, Or if it was really severe, you know, with anaphylaxis-like symptoms, well, then clearly they do need some kind of workup and thought and potential re-exposure in a controlled setting, which is what our allergy colleagues do. But for everyone else who has just you know, either nothing, and often the family history of penicillin allergy. I had this just last week where a child came across with a nasty infection, was given just dreadful antibiotics because there was a penicillin allergy, strong history in the family. The problem is there's a strong history in the family because if one person has it, they then confer that thought process to the next person, to the next. And when you unpicked it, no one had actually had an allergy to penicillin in this family. So we gave this child Carmoxiclav and they were absolutely fine. So you just got to do a bit of stratification. If it's more than an hour post-dose and they had a rash, so just cutaneous symptoms, then you've got every justification to challenge it. And I think this could be done by nursing colleagues. It could be done in primary care, although it's not going to be done in primary care. But I think our opportunities for us in hospital, like we did last week with this family, we've now been able to take off a penicillin allergy label, even in one child, and it does have a tangible impact. So I think this is something for all of us to do. We're not really going to get commission services of pharmacists going around and challenging people. You know, I think this is part of our AMS responsibilities as frontline clinicians. Pill swallowing super important because suspensions are disgusting and they don't travel well. They degrade more, so you're not totally sure what dose you're giving, etc. And environmental impact. We've got lots of information about pill swallowing on the Healthy Together website, which our colleagues in Newcastle have developed some really brilliant pill swallowing resources. And you know, it takes work. But these children need some kind of a big pat on the back if they manage it. And you can get children from about 6 years, 5, 6 years of age, potentially swallowing tablets. And we do with some of our kids with HIV. We managed to get them swallowing tablets really, really young. Yeah, there's good guidance about duration. You know, we've moved to 5 days of treatment for tonsillitis. We've moved to 3 days for pneumonia, according to NICE as of last, as of a couple of weeks ago. And that cumulative duration, the longer you treat for, the higher the risk of adverse drug reactions. It goes up by about 3 to 5% or 7% for every day increased exposure. So these things do make a difference. And then going on to communication, I think what we document, the indication is really important. Go for it, Andrew.
I'm so sorry, Sandra. Thank you very much. In terms of that latest NICE guidance on pneumonia, it seems very dramatic, doesn't it? 3 days. And I'm sorry having just sped back, but so just in so I suppose potted version. And the data seems strong and consistent to you for that. It just seems a very large sea change to what we were used to.
It's the Arctic PC study, which was a primary care study of non-pneumonic lower respiratory tract infections in children that showed no difference between antibiotics and giving antibiotics, so placebo versus antibiotics. So for me, actually, what that's telling me is that nearly all children under 11 years old, and they've done it under 11 for some reason based on those studies, is that almost none of them needed antibiotics in the first place. So it might be that this is a bit of a journey going from 3 to 5 to 0. Clearly, if a child has got a nasty lobar pneumonia, I would not be only giving them 3 days of antibiotics. So you're absolutely right to pick up on that. Thank you for that, Andrew.
And two different questions.
Yes, yes. I think you're saying the same thing as I was just thinking. We're probably seeing a difference. Certainly the ones we admit are different, aren't they, than those?
They are. We'll come to those admission ones in a moment, actually. But yes, I think you're right. I think that for us seeing proper lobar, toxic looking, not severe sepsis, but, proper severe infections with bacteria in the chest, lobar pneumonias, I wouldn't feel comfortable just giving them 3 days because I don't think the studies that have been done, they've excluded those sorts of children, actually. So yes, yeah, absolutely right. So decision making, you get someone who says query sepsis, fever, start IV ceftriaxone with almost no information there, 10-month-old boy, we've all seen it. And then you coming up, and this is where we find it challenging because often it's a poor SHO, someone has seen them in ED, there's no space at the inn, they go home on ceftriaxone, they come back the next day, a nurse probably gives them another dose of ceftriaxone, and then they come back at 48 hours and you're expected to make a sensible decision. That person is clearly not there because they're on annual leave or something, or they're in the middle of night. And you have no idea what you're supposed to do. And I do think that we've got to be really clear about the indications, what the plan should be. I'm not saying this is easy, and maybe we do need to think about, for a child being started on IV antibiotics, or the person who starts them maybe does have to complete some sort of pro forma saying, I think the infection was X, the focus. I think that if Y happens, then they should switch at this point. If these tests come back negative, I'd like them stopped at 24 hours. But none of that is almost ever documented. Anne-Marie.
I was just going to say, Sanjay, one of the things that is a real bugbear of me is when people don't put their impression at the end of their notes. I was like, the only bloody point of our entire job is to put your impression, because if you don't, the next person coming along is just going, and it happens all the time, particularly on the postnatal babies. Like, actually, were we worried about this baby? Were we not? Anyway, but yes.
I think my bugbear goes one step before that, which is people not being able to take a proper history. I think if you don't take a proper history, you can't come up with a proper impression. So I think we've moved so far away from what is good clinical practice and what do we offer as clinicians that we do need to get the basics proper. We need to do the basics properly. I mean, get my grammar correct. And I think you're absolutely right. I think we have to put impressions in. We've got to put clearer plans in, because people just think it's the easy option. And I appreciate our departments are busy and we've not got enough staff and people are always sick. I mean, that's always the case. We work in the NHS. You want to work somewhere else, fine. You work in Australia, you'll have more people to work with and maybe less burden of disease, but that's not the case we work here. Andrew.
It's lovely to hear that, because those are all the things that are my bugbears too, and I feel like I'm an old dinosaur who nags all the time. But it does come down to how we train our juniors as well, but then that's also difficult because we are so busy and we are taking, but so I don't have an answer, but it's nice to hear that other people think the same thing.
If we agree that is basic standards of care, then we should be able to audit against it. Yeah. So we need to make it clear what the because I don't think it's fair to expect people. I think it is fair in this case. You should be able to take a proper history and write an impression down. But let's say that that's challenged because those individuals weren't told that they were expected to take a proper history, think of differentials and write an impression and a plan. Then we need to make that clear, that the expectation for any child started on antibiotics, either ambulated or brought into hospital, is that there is an impression and a plan. And then you audit against it. And I'm not saying you name and shame, but potentially you name and shame. People will then start documenting better. And I'm not saying documenting for the sake of it. I'm like you, I hate excessive documentation and form filling, but I don't think that this is excessive. I think this is basic standards of care, actually. So, almost finishing this section off, because I'm mindful of the time. What am I trying to say? Severe sepsis does happen, not so often, but if it does, you need to recognise it, give antibiotics quickly, because they do make a tangible difference in children. The very small number, the less than 1% of febrile children presenting to ED who have severe infection, severe sepsis. I mean, get the right samples off, get the right volumes of blood cultures. Blood culture volume is super important. Don't do unnecessary tests where you then get bound by the result, and that's where our biofires and mycoplasma positivity and stuff comes in. Recognise that there are harms in broad spectrum antibiotics. Use orals where possible. I'll talk about that in a moment. Prescribe the shortest course possible. When I say possible, it's still aligning with current guidance and evidence, and get the dosing right. If they need antibiotics, and also we're going to talk about frequency and palatability and orals and tablets and stuff. Okay, then focus, IV to oral switch. As I said during that first talk, and this is once again the perform data, we, like many other countries, paediatricians in many other countries or ED doctors, when children have bacterial infections, we very often give them IV antibiotics because we think that, God, they are different because they're here. And I get that, it's not just the UK. Children get a lot of IV antibiotics. We know that our oral antibiotics, many of them have excellent bioavailability, from some that we shouldn't be using, like linezolid, which has amazing bioavailability, to drugs even such as cefalexin that's got very good bioavailability. Fluclox, not as good, and Fluclox is a little bit complicated because of taste of suspension, but many of our antibiotics got excellent bioavailability. The bottom line is, if the bug's in your body, it has no idea how the drug has got into your body. What we're interested in is the amount of drug in the body compartment that the infection's in. And that's what we need to think about. So bioavailability is on our side in children. there may actually be benefits of, there are lots of benefits of oral antibiotics over intravenous. One is AMR, and as I said, we give lots of ceftriaxone. That does the broader the antibiotic you give, it does two things. It selects out resistant organisms inside you that are already there. And for children who are in hospital settings, especially our most intensive hospital settings, such as neonatal units and paediatric intensive care units, you are more likely to acquire some of the nasty bioflora of the department if you have been opened up to them. And that opening up is done by having tubes in, by having a tract being ventilated, but also by being on broad spectrum antibiotics. So we're just adding an additive thing that is making it more likely that these children be colonized with horribly resistant bugs, which when they then get that ventilator associated pneumonia will not be a simple community-acquired thing that we can give amoxicillin for, but will be some god-awful stenotrophomonas or some multi-drug resistant pseudomonas that I then have huge challenges curing or treating. Obviously patient experience, oral versus IV, it's a no-brainer. I think the worst thing we do in hospitals is to stick needles in children, especially in the middle of the night when we try 17 times to get in a cannula. And for parents, that is always the single most distressing thing they see in hospitals, and because it happens so frequently. Also, you get out of hospital more quickly if you're on oral antibiotics. All of the studies have shown that, and I'll show you some neonatal stuff that backs that up. The cost we've spoken about before for families, etc. There's obviously nursing time, massive. We talk about not enough staff in our EDs. There are definitely not enough nurses on our wards, and the nurses we have shouldn't be preparing IV antibiotics and administering them. They should be actually doing ops and caring for patients and listening to parents. But it takes vastly longer, obviously, to give. And then you have someone like me that says, you should give a narrow spectrum agent like Fluclox. Well, that's 4 times a day. So that's why we then push ourselves into ceftriaxone, because if you're going IV, well, then it does make sense to go for the thing that's once a day when you've got no nurses to administer antibiotics anyway. So, we're creating a rod for our own back by pushing IVs when the IVs then take so much time for our nurses to give. Obviously, extravasations, especially with certain types of drugs. Health economics with length of stay, costs of drugs, bed pressures. And then this bit is awful. We send our rubbish all around the world because that's what we do, because we're a rich country and we pay poor countries to take our rubbish. And then this kind of stuff ends up in their landfills, which will last there for thousands of years. And then we'll end up in our oceans. And then we talk about microplastics that we then eat when we eat fish and chips. And none of this is good. I think the green agenda and the green impact is absolutely ginormous here. Nick spoke a bit about pharmacodynamics the other day. I just want to remind you that this time over MIC concepts for beta-lactams. Beta-lactams are most commonly used drugs, and this is how they work. You want to have as much time in a 24-hour period above the minimal inhibitory concentration to make them work as effectively as possible. Clearly, if you gave them as a continuous infusion, that might be the best. Clearly, if you dose them totally incorrectly and bundle all your doses of a 3 times a day dose to midnight, 6 and lunchtime, that's not cool either. So this is a graph of concentrations in the blood. On the left, the same drug as a single dose given IV, and on the right-hand side, the same dose of the same drug given orally. And what you can see is that with IV, obviously it whacks straight in very quickly, which is why in sepsis, where the gut doesn't work also and stuff, you want to give an IV dose. But actually, for an oral dose, you get high levels very quickly that are high above the MIC, very quickly. But you look at the shape of those graphs, and the time over MIC for the oral is significantly longer than from the IV. You're talking 240 minutes versus 120 minutes. And so there is actually a theoretical advantage to oral dosing rather than IV for certain drugs, actually. And we have there's a lot of data now that have really shifted that paradigm away from IV antibiotics. A lot of this came originally from our adult colleagues. They did some massive, brilliant studies of bone and joint infections and endocarditis. And now we're doing some work on Staph aureus, and we've done stuff with gram-negative infections. But the ones that have really pushed IV to oral switch have been the bone and joint infection studies and the infective endocarditis ones. And actually, standard of care in adults for at least bone and joint infections is relatively early IV to oral switch. I think we've been ahead of the game anyway in paediatrics. We've been switching quite early, but not not across the board, and I still get phone calls from certain hospitals where the orthopods or whoever are insisting on 6 weeks of IV antibiotics, and it's a catastrophe. We recognise this in children, and so there's lots of a strong narrative now, and data. And so data for pyelonephritis, so for a bacteremic upper UTI, actually the outcomes are identical if you give 7 or less days of IV before, or give more than 7 days. We often will give 3 days, 2 days IV. If they're improving, we'll switch them to an appropriate oral antibiotic, even for a bacteremic UTI, and treat for a total 7-day course. The same goes with non-bacteremic UTIs. Obviously, they're easier to manage. You really don't need prolonged courses of IV. You can do all switches very quickly. Bone and joint infections, in line with the Aviva study, our guidance is to switch early. We usually switch at 48 hours. Even for Staph aureus bone and joint infection, we get them onto cephalexin and get them home and treat for 2 to 3 weeks with septic arthritis, or 3 to 4 for an osteomyelitis. And that's in our national guidance on the BSAC common infection pathways. But this is really interesting. This is kind of pretty hot off the press as of last year. This is bone and joint infections treated either exclusively orally or with initial IVs prior to an IV to oral switch. And in fact, there were absolutely no difference in outcomes between exclusive oral regimes. And this was a randomized controlled trial, a multi-center RCT from Denmark, where they're much braver at doing RCTs than us. So, it's telling us that even for the big hitters, where people wanted 6 weeks IV, it makes absolutely no difference. Clearly, if they've got an abscess or they've got something that makes them more complicated, yes, you need a slightly nuanced approach. But for the majority of children that aren't comorbid, who've just got a community-acquired septic arthritis, you can treat from it. We're not brave enough to do that yet, but it's just giving you an example of what's being done. The new kid on the block is neonates. We've always been terrified of neonates, and these guys, initially from Holland and then Denmark, conducted a couple of pretty big studies looking at children with late onset sepsis, or early and late actually, who they switched to oral antibiotics quite early. So we would treat exclusively with IV generally, or we have historically in this country, and they were doing oral switches at a few days, at 48 hours. They were getting them out of hospital obviously more quickly, and their outcomes, readmission rates, clinical deterioration, was identical between the two groups. Clearly the exclusion criteria important for that Dutch study. They excluded culture-proven bacterial infections or severe sepsis. Okay, that's fair. The next group didn't. So this is lost a slide. It's a Danish study where they didn't actually exclude the culture-proven positive children, and actually even with early IV to oral switches in those, they had identical outcomes between the two groups. And our colleagues in Exeter have done some work on this, and they've had good outcomes, and they've managed to switch a number of their children and complete their treatment course at home. I just want us to be a little bit mindful of this, because I'm not still totally won over by this approach. And I think that doing the basics properly, as we were talking about, history taking, writing an impression down, a plan, if you don't do the basics properly, then it's hard to actually interpret what the impact of these sorts of interventions are. And I think the basics for early onset sepsis are a good screening tool, and Kaiser is a tool that many people use. And then potentially the realigning one's CRP thresholds. We've used 20 as the new 10. So in our experience here in Southampton, it's with Kaiser Permanente, we've had a significant reduction in use of antimicrobials commencement in neonates from about 11% down to 6%. We've nearly halved it off the back of that. And then through this work that Kelly's been doing with 20 is the new 10, we've managed to stop antibiotics 48 hours in the majority of babies on the postnatal ward who were otherwise being treated with 5 days of antibiotics. And this is the postnatal usage of cephalosporins in those otherwise well babies who aren't on the neonatal unit. And so Kelly kind of looked into the potential impact of that NOAA, that IV to oral business in neonates in Southampton, where she's worked really hard on early onset sepsis. And so she looked at babies on antibiotics for more than 2 days and showed that the majority of them are, it's 5 days for most. And that's often because they've got a CRP of 25 or something silly like that. So there's still work that we're ongoing to try and push that CRP thing, or move away from CRPs entirely, potentially, as some countries have done. And so she found that actually there weren't that many eligible babies that would have been eligible for NOAA. Many of the ones that we had, some of them had CRPs over 50, so they wouldn't have been eligible. And so actually, if you do the basics properly, the IV to oral switch, what your risk is that you're just allowing people to get out and get jail cards so that they don't have to make a decision at 48 hours or 36 hours and stop antibiotics. They just give a few more days because it's oral and they're out of sight. So I'm still to be totally won over with this approach. I'll do the other stuff first. I do think there are indications for definitely giving IV antibiotics, sepsis, for the reasons I said. Also, your gut doesn't work. You want to get it in quick, get it up high levels quickly. I think if your gut doesn't work, or if there isn't an oral option because you're managing a highly resistant organism like a carbapenem resistant or an ESBL organism that's resistant to Septrin and ciprofloxacin. We've got some really nice guidance. This was developed by WPAS and UKHSA. I think this is really good for our pharmacy colleagues, actually. You know, pharmacists are reviewing antimicrobials or all drugs at least Monday to Friday on wards. Paediatric pharmacists do that. I think they should all be using this IV to oral switch tool to empower them to actually challenge prescribers or people doing the ward round to potentially do oral switches. And, you know, I still have to be a little bit mindful, and that picture keeps disappearing, but basically it's saying that, you know, just be mindful of your oral agent if you switch. It's got to taste okay. You know, clindamycin's horrible. Penicillin V is often pretty disgusting in many preps, so we tend to give amoxicillin. Fluclox is disgusting. We tend to give cefalexin. You know, if it's, you really try and push tablets better. And frequency, so 4 times a day dosing, the compliance really does drop off if you go beyond 3 times a day. So we would rather go BD amox than TDS amox if we can. We'd definitely rather go TDS cefalexin than QDS flucloxacillin. So those are some of the things. With some orals, you can't push the dose as high as you can do orals because of the side effects you could generate, you know, gut irritability, but not so many in our hands do that. And this is a QI project done from colleagues up north, our colleagues from Sheffield. You know, it's a bit like the thing we were talking about, write an indication down. This is an IV to oral switch review where you try and, if a pharmacist has used that UKHSA tool, and then just put that in and sort of say, yes, I think that this child meets the eligibility criteria. You know, are you happy? And then if they're not happy, they need to justify why they're not happy and need to start. And almost my last slide, because I think we've just about run over, is that, you know, there is room for improvement. This is, you know, Judith mentioned, you know, our children are different. I agree, the ones who come in with pneumonia are different to the Arctic PC trial. But we have a lot of children that come in with respiratory distress who are only being brought in because they need oxygen. And people are then want to cover infection because they're not sure. And then they invariably give IV ceftriaxone. And this graph is American data, or their American data about exclusive oral use in children being admitted with pneumonia. You know, very few children with pneumonia need IV antibiotics unless you're overwhelmingly septic. And we said earlier that respiratory sepsis is not really a thing compared to urosepsis. It's much less, or your gut doesn't work, or you've not got an oral option because of resistance. You know, that about 1% of children would fall into that category. And yet in our hospitals, about 100% of children being admitted with a lower respiratory tract infection and end up at least starting on IV antibiotics before a switch, if they have a switch at all. And that's reflected in some of the American data. There are very, very few hospitals can just use orals. And I think this would make a really good QI project, actually, that we can do in all of our hospitals and have a massive impact on our nurses and those poor children where people are trying to cannulate them at 3 a.m. And so conclusions are many. You know, we spoke about sepsis, we spoke about diagnostics. These are all areas we can tighten up on. We need to know this in order to then have our infection team then role model this kind of stuff and convey the evidence supporting it and the impact, most importantly, on the people who are making those decisions. You know, the bits then about whether to start, if to start, then whether to give IV or oral, IV to oral switches, choice of antimicrobials, uses of guidance. But definitely the big thing is the IV to oral switch narrative. That's really got strong. We are giving less and less IV antibiotics across our hospital and definitely across our OPAS service. And there are so many benefits of early IV to oral switch or exclusive oral therapy. And the decision aids we've got, you know, they're quite robust. And actually people who are not the prescribers, but who are routinely reviewing charts, get some confidence because it's a nationally developed resource that they can use. So I think on that note, I'll probably end. We definitely have time for questions if people want to ask questions. We've had some obviously during the chat. Yeah, Judith, Andrew.
Thank you very much, and magnificent. Thanks, Andrew. Certainly the highlights of the week from educational point, and really, really eye-opening stuff with the Ivy Tour Switch. Strangely enough, on a bit of tangent. So one of our stop motion materials we've made for the resident doctors is actually a stewardship thing about the logic as adults of using co-amoxiclav and then hopefully rationalizing quickly. Strangely enough, pharmacy have requested me to make specifically one for IV to oral switching, obviously focus on adults, but if it's okay, I can WhatsApp you the video link and see what you think, because I'd be glad to obviously to work on one for the use of the network if useful.
That's perfect. Yeah. No, is this for pediatrics or adults or both?
Well, I'm working. Requests I've had so far have been actually adult, etc. But happy to adapt and review, and we could talk after the meeting.
Great to hear that sort of work being done, and that's the whole point of this network. Without this meeting, we'd have never heard that, and it may well be that others want to use this as well. And so, sharing of good practice super important. So, thank you. Really good. Seb.
Yes, Sanjay, sort of interested. You've sort of touched on it. What do your sort of European counterparts think of us in terms of, as you've said, we use a heck of a lot of ceftriaxone. It sounds like we're using way more. Do they look at us and think, God, you guys are way behind the curve in terms of antimicrobial stewardship? And if so, are there any hints of why they are doing it better?
Yeah, so the big one that comes out, and actually, unfortunately, I mean, not unfortunately, but the people that get kind of fingers pointed at them are our colleagues in Greece and Italy and Spain. So they get big fingers, but they have ridiculously high rates of resistance. So now they're fighting a losing battle because, once the horse is bolted, you then have to use broad spectrum antibiotics because their baseline rates of resistance are so high. For us, people don't until we interrogate the data and present them the way we do, it kind of goes a bit under the radar actually, but the answer is entirely to do with the sepsis narrative. No other country in Europe has that sort of narrative. It's got so out of hand in this country. No one has ever heard of a sort of a sepsis campaign in the way that we've done it nationally. So we have created that entirely, and the harm that's been generated to children. That's why we are so disproportionately high on third generation cephalosporin use.
And just Abbott, and I won't digress too much, but what is the response from the organisations that are there promoting that? Because they've got a lot of.
So the answer, and Damien, some of you will know a colleague called Damien Rowland, who is a PEDS ED person, Picura, whatever the research network. He used to chair that, and he's also now does the Pews work at NHS England. He has been banging this drum for a number of years to totally deaf ears with a nice. I've met with Ron Daniels from the UK Sepsis Trust. He acknowledges that it's kind of gone a bit wrong for children when he's being fast bleeped or crash called to PEDS ED to see a child sitting on their mother's lap smiling at him. He's like, okay, wow, maybe something's gone a bit wrong. So I think he acknowledges it, but NICE have historically been totally unwilling to review any of the narrative that we have drafted. I know the Archem published something recently on it. I don't know, they responded to NICE. So I saw their draft response to NICE where they've essentially described what we've been talking about during this call. NICE have been wholly unresponsive to date for some reason. That has to change, clearly, and it will change. It will change. I have no doubt. It's just proving more difficult when people are so wedded to NICE guidelines. Not wedded, people are so scared of deviating from NICE guidelines. That's the challenge we have. But yeah. Okay, I think if there are no other questions, I mean, thank you for joining. I know it's been a smaller group today, but hopefully others will watch this or share it with your colleagues or whatever. Next week, we'll meet same place, same time. And then the week after, do get your IPC colleagues to join us, because that will be IPC is week 5. And then we have a few weeks break and we're meeting face to face for that day of workshops. And it really would be good to get a core group of people from each acute trust to that, because that's when, the stuff that Seb's raised about your ED and, shortages, that you just give, we don't have good answers to this thing, but actually we need to kind of, within our teams, that are hospital-based teams, try and work out some of this sort of stuff, or at least discuss it, brainstorm it. Okay, have a great afternoon all.